session, Genetics for Clinician. Genetics today, as we all know, gives us the clinical decisions that we make every day, taking from infertility to recurrent pregnancy losses. It influences the way we diagnose, manage, and treat our patients in day-to-day practice. To help us bridge this gap between genes and clinical practice, we have today our expert, Dr. Sangeeta Khattar. She has done her DNB in clinical genetics from Sir Gangaram Medical Hospital, Delhi. She is a senior consultant in genetic medicine at Jindal IVF, Chandigarh, specialized in reproductive medicine. I welcome you, ma'am. Over to you, ma'am.
Unmute yourself, Sangeeta. Sangeeta, unmute yourself.
Yes. Good evening, everyone. Am I audible now?
Yes.
Yes,
Okay.
ma'am.
Good evening, everyone. Today we have been here for interactive session, and I'm very thankful to the seniors who have joined me. I hope I justify my presentation today. So I will start. Slides are not moving.
Just click once.
Hmm.
Click on the slide. It's not moving.
No. Now started. 1 second. Yeah, so this course is the result of hard work by Dr. Jindal, who is our mentor. And she's always, into academic activities and keep pushing us. So these course details I have just shown in this slide. So this is 1 hour online session every fortnightly, 6 to 7 p.m. These are interactive sessions on practical day-to-day management of the clinical scenarios, and these are 4 series of 6 sessions each. We are going through series one, season one. So series one contains basics of infertility management, which is going on. We are in series two is ovulation induction and stimulation protocols. Series three is the infertility management with various diagnoses. Series four will contain ART. क्या हो रही है? So we have already gone through the session one, session. Hello. Hello. Am I audible?
Yes, ma'am. You are audible, ma'am.
Okay. So we are in the session 3 today, where I'm going to talk about the day-to-day genetics for clinicians. And after me, there will be a session by Dr. Nidhi. I will be explaining late. Now we should start without getting delayed. So, first of all, my first concern and most important question is that when to refer a patient to a geneticist. So this is the most important question, because most of the time patient come to me in the post-conceptional prenatal period. They have a lot of history. At that time, I don't have also that much time to genetic evaluation and pertaining a diagnosis or recurrence counseling, or what can we do at that time. So we have limited options, reproductive options as well. So, in preconceptional period, if infertile couple evaluated and male is detected to have azoospermia or oligospermia, and female partner is having uh, premature ovarian insufficiency or decreased ovarian reserve. 1 second, actually this is disturbing. Yeah. So, if any history of genetic disorders like thalassemia, sickle cell anemia, hemophilia, congenital adrenal hyperplasia, Duchenne muscular dystrophy, spinal muscular atrophy, myotonic dystrophy, in family or in previous children, so they should come preconceptionally, so that we can properly evaluate the case, and we can make a reproductive plan for them. And any history of previous IUD, child with neonatal or infantile deaths, autism, global developmental delay, intractable epilepsy, short stature, congenital heart defects, polycystic kidney disease in the family members or in the previous children, muscle weakness, ataxia, recurrent infections or decompensation attacks of pneumonias, recurrent fractures, joint dislocation, congenital deafness or impaired vision. And most of the time coupled with recurrent pregnancy losses and abnormal karyotype report. As we know that in 5% of the RPL couple, we find balanced translocation carrier status of one of the partner. So they should be referred preconceptionally, ideally. And any personal or family history of hereditary breast, ovarian, endometrial, gastric, pancreatic, colon, prostate cancer running in the family, or maybe young age of onset, that could also be genetic. Before pre-implantation genetic testing, because most of the IVF centers, they are adopting to the PGT, and PGT is a very innovative technique. But before planning a PGT, a geneticist advises always required. Or carrier screening. Carrier screening is basically checking the genetic profile of the couple before pregnancy to check whether they are carrying any risk of having genetic disorders to their children. That means X-linked or autosomal recessive disorders that might be causing morbidity or lethality to their children. We diagnose them before the pregnancy or before their planning so that we can make a proper reproductive plan. In prenatal period, we usually get referral for couple with unusual HPLC or HB electrophoresis report. Ideally, these patients should be screened in prenatal period, pre-conceptional period if they come to a clinician. Pregnancy with abnormal dual, quadruple NIPT results or malformations or soft markers on ultrasound. And postnatally, because most of the private nursing homes, they are conducting the newborn screening for their children. So abnormal basic or advanced newborn screening results. That is the reason for a referral to a geneticist. So before starting the case, I would give an overview of genetics of male infertility. So we know that infertility affects 15% of the couples. I think it is more than that nowadays. Incidence of chromosomal abnormalities in males, that is inversely proportional to the sperm production. That means karyotype is advisable only in azo or oligospermia or recurrent pregnancy losses or unexplained repeated IVF failures. And identifiable genetic abnormalities, they are detected in 15 to 20% of azoospermia cases and 5% in oligospermia cases, and which is a major chunk. So I will start with the case. I usually get a referral for infertile male with non-obstructive azoospermia, and hormonal profile is suggestive of hypergonadotrophic hypogonadism. That means high LH and high FSH. Patient is worried about the option of micro TC, that is the testicular sperm extraction, and they are worried what is the risk to the offsprings with non-obstructive azoospermia, what are the success rates, what is the role of geneticist here or genetic testing here. So we usually advise karyotype and Y microdeletion in such cases. Now, what are we expecting from them? Why genetic counseling? What genetic counseling? So expected karyotype. Hello, I am audible?
Yes, yes, carry on.
Yes, ma'am.
Okay. So
Carry on.
expected. Yeah, ma'am.
Yes, carry on, please.
Okay. So expected karyotype in cases of non-obstructive azoospermia with hypergonadotrophic hypogonadism. I will be discussing the commonest karyotype we get in our practice. One is the Klinefelter syndrome, which is the most common karyotype observed in azoospermia or oligospermia. 47XYY, we call it as Jacob syndrome as well. 45X, there is mixed gonadal dysgenesis of 45X and 46XY. There are two different cell lines running into the body, and they make it mixed gonadal dysgenesis. And 46XX male. So the phenotype is male, but the genotype is 46XX. We call it as testicular DSD. These are not commonly seen, but yes, these can be the cause of karyotypic, non-obstructive azoospermia. And in oligospermic males, in 4% of the cases, we can get balanced translocation that can be reciprocal or Robertsonian in these cases. I will talk about the Klinefelter syndrome in few, but a bit detail. Incidence is 0.1 to 0.2% of the newborn males. Prevalence is 1 to 2% in infertile males, 0.6% in severe oligospermia, and 10 to 12% in azoospermia, 10 to 12% of Klinefelter. So infertility is due to impaired spermatogenesis due to progressive hyalinization, fibrosis, degeneration of the germ cells in the testes, which usually starts at puberty, and testicular extraction of the sperm that is successful in up to 70% of the cases at centers of excellence. I would say we have a center of excellence, Jindal IVF. So, because of the normal karyotype, focal areas where the normal karyotype can be seen in the gonads. So, that is why we are able to retrieve the sperms. And diploid sperm incidence can be 6.3% or maybe more. That means we usually get the haploid sperms. But in these cases, because the karyotype is already 47XXY, so we can get diploid sperms as well. That would be leading to the sex chromosomal aneuploidies later on. That is why PGTA is advisable in these cases. PGTA is the pre-implantation genetic testing for aneuploidies. I will be discussing these in detail in my later slides. So for aneuploidies, we usually advise PGTA in Klinefelter syndrome.
Dr. Sangeeta,
Yes, ma'am.
can I ask you a question?
Yes,
Don't
ma'am.
think 70% is little high, what you are saying? And the
As per
second
the studies,
second thing
ma'am.
is, if patient doesn't opt for PGTA, then I
Yes,
think
ma'am.
prenatal has to be done.
Yes, ma'am. Yes, of course.
Yeah, but
So PGTA, if they are not willing for PGTA, then we advise them prenatal diagnosis for sure.
and I think 70% cases one has to go by the testicular volume and testicular and hormonal profile and many other things. But
Yes,
what I would like to emphasize here is, even with major karyotypic abnormalities, there is still some hope for these men.
yes, yes, ma'am. Yes, ma'am. So that is why we advise every patient for karyotyping so that we can prognosticate that case. So XYY Jacob syndrome not seen very commonly, and patient can be normal sperm count in many cases and can be azoospermia. So again, the management is same, and PGTA is still advisable because they can be risk of sex chromosomal aneuploidies, and as per MAP, prenatal diagnosis as well. So, second cause of non-obstructive azoospermia with hypergonadotrophic hypogonadism is Y microdeletion. What is Y microdeletion? So, this in this picture, I have shown the Y chromosome. So, Y chromosome basically it has genes mostly. I would say 100% genes for spermatogenesis. So, any problem in the Y chromosome will lead to the spermatogenic failure or decreased spermatogenesis. So there are some areas of on the Q arm which, if micro deletions, basically some microscopic deletions, if they are there, they can lead to impaired spermatogenesis. So these areas they have divided from the centromere to the proximal part of the Q arm. AZFA as azoospermic factor A, B, and C. So depending upon the region of deletion, so this is seen in up to 10% of cases of non-obstructive azoospermia, and we advise bispecific PCA from the genetic testing point of view, or MLPA. And we say tell the patient that it will take around 1 to 2 weeks depending upon the lab. So why do we advise testing? So two main reasons. One is the prognostication, another is the recurrence risk. Because in AZF-C deletion that accounts for 80% cases of impaired spermatogenesis and no sperms in ejaculate, but this has got good prognosis. And testicular sperm retrieval is 60%, which is a ray of hope for infertile patients when they are hopeless that they will not be having their male partner's sperm. And recurrence risk, that is 50% to the male children, and size of deletion can be variable because of the recombinations. So these are the most important factors. Why do we go for Y microdeletion and genetic testing? Now I will go to the another case, non-obstructive
Ma'am,
azoospermia.
here
Yeah.
Here I have a question. Like,
Yeah.
ma'am, when to advise why microsome micro deletion versus karyotype as a first line investigation in male infertility?
In male infertility, if I have a case referred for non-obstructive azoospermia with hypergonadotrophic hypogonadism, so I am suspecting something related to the gonad. So I will advise karyotype as well as Y microdeletion at first place.
Okay.
Because karyotype takes 3 weeks for the report and Y microdeletion also 2 weeks for the report. So both of them, if done together, can save a lot of time for the patients as well, and they can help in counseling also.
Sangeeta,
Okay,
how
got
much
it.
does it cost? Why microdeletion?
Y microdeletion at our center, it is 6,000. I think most of the centers in Gangaram also we used to do it in 6,000 only.
Okay.
Shall I move forward?
Yes.
Yes, ma'am.
So another case I would like to highlight is non-obstructive azoospermia with hypogonadotrophic hypogonadism, that is low FSH and testosterone. Now, most of the hypogonadotrophic hypogonadism, they can be genetic or acquired. We all know that. And genetic factors are very less, although 3,000 genes are responsible for spermatogenesis. And each and every day we are discovering new genes. But at present, I would say only few percentage of cases can be genetic. And most common genetic single gene disorder is Kallmann syndrome, and clinical features can be anosmia and normosmia as well, depending upon the genetic defect. And they can be midline defects like cleft lip, palate, single incisor in the male patient, infertility, unilateral renal agenesis, deafness. And that can be X-linked, autosomal dominant, autosomal recessive, depending upon the gene which is involved. So we are on the way to discovery of new genes for spermatogenic failure, for hypogonadotrophic hypogonadism, and I have seen many OMIM genes are also there. So in genetic counseling, in these cases depends upon the inheritance, but we got only 5 to 10% cases I would say are genetic. Otherwise, they are multifactorial, and we leave it to the fertility specialist for the treatment. So
So
another case.
can we say, Sangeeta, that we refer to you only if there are some other associated stigmata of genetic disorder? Otherwise,
Yes, ma'am. Yes, ma'am. Most of the time.
hypogonadism, we don't have. All the patients should not be referred.
Yes, ma'am. Yes, ma'am.
Okay, thank you.
So, another case, infertile man with obstructive azoospermia due to CBAVT, congenital bilateral absence of vas difference. So, patient has been advised ICSI with percutaneous epididymal sperm aspiration and testicular sperm aspiration. Now, why do we want geneticists to get involved into this? Because I will come to the next slide. So CBAVD, that is detected in 1 to 2% of infertile men, 6% of the males with obstructive azoospermia, and cystic fibrosis and CBAVD. They are both the spectrum of a disorder which is due to mutation in the CFTR gene. So, as I have shown into this picture, the autosomal recessive inheritance of cystic fibrosis. So, cystic fibrosis is the severe form of CFTR gene mutations, and this is an autosomal recessive. That means if parents are carrier, I have shown these two copies of the chromosome. One is defected in red, another is normal is in blue. So, if parents are carrier, that is they are having one copy of CFTR defected gene, they can have 25% chances of having an affected child with cystic fibrosis, which is the severe form. That means child can have recurrent pneumonias in infancy, and that can lead to lethality, chronic lung disease, pancreatic insufficiency, and endocrinal disorders. So we are more worried about the cystic fibrosis than CBAVD. That is why we advise, because in CBAVD is the milder form of the cystic fibrosis, and that is again due to the CFTR gene mutation in 80 to 97% of the cases. And carrier rate, that means parent having one defective copy of the CFTR gene. That in normal cases, in normal population is also 1 in 25 to 1 by 65 in different populations, and Indian population it accounts to 1 in 60. So that is much more than anything else. That is why in CBAVD, we can get one mutation in the CFTR gene in one copy or sometimes in the two copies. So now we are worried that if other partner is also having the carrier status, we would be landing up with the affected child with cystic fibrosis. That is why we are going for CFTR gene sequencing in each and every case with CBAVD.
Dr. Sangeeta,
Yes, ma'am.
I have a question here. See, there are so many mutations which can be abnormal. So, if the husband has different mutation and the wife has different mutation,
Yes, ma'am.
does the still risk of cystic fibrosis would be there in the child?
Yes, ma'am. Yes, ma'am. Of course. Actually, the mutations that depend upon the mutation, because there are different spectrums of mutation. There are severe mutations which lead to the total loss of protein. Sometimes there can be partial protein deficiency. That mutation can be causing partial protein deficiency. Depending upon the mutation profile of that patient, we consult the patient. We recently had one patient where husband was CBAVD, and we did advise the carrier screening of the partner, and she unfortunately she was also detected to have a carrier status for a severe mutation. So we again went to the husband, and then we checked the husband. He was already having one mutation that was also severe mutation, one copy of the gene, and we did the PGT for this case, PGTM for this case. I think you remember, ma'am.
Yeah, yeah.
So that is very, very
So,
important.
so one thing again I want to highlight here is the single gene mutations are amenable to PGTM. That is one important thing why we are going in so much detail to understand the mutations and the vertical inheritance and the transmission pattern, that so that we can counsel the patients properly, and then maybe we can select normal embryos and give
Yes,
these couples chance for a normal pregnancy.
yes, ma'am. Shall I move forward now?
Yeah, sure.
Yes. So another case. Now I have come to the female infertility. Female partner with primary or secondary amenorrhea or premature ovarian insufficiency or decreased ovarian reserve, which is very, very common nowadays, and hypergonadotrophic hypogonadism. So what is the role of genetic referral here? You will ask. And why genetics? Because there can be association with chromosomal and single gene disorders. Chromosomal, I think everybody knows that there can be primary amenorrhea and Turner syndrome or mosaic Turner syndrome. Mosaic Turner, that means two cell lines are running in the blood cells. And that is one is of 45X and another is of 46X. They can be having a milder phenotype, but secondary amenorrhea can be the presentation or decreased ovarian reserve with another thing that can be seen. And another most important karyotype abnormality is translocation carrier status of the female. She can be the balanced translocation of 13, 21, because on 21 also there are some genes which control the fertility, or any chromosome involving translocation involving X chromosome. Mostly they can lead to decreased ovarian reserve or infertility. And monogenic causes of decreased ovarian reserve. This is most important slide, because decreased ovarian reserve is seen in 10% of the women infertility, and strongest single gene association of decreased ovarian reserve or premature ovarian insufficiency is with the FMR1 gene. FMR1 gene, what is this? So FMR1 gene is the gene present over Q arm of the X chromosome, and this gene is mostly expressed in the brain, and defect in this gene causes mental retardation in male child, because this is on the X chromosome. Male is only having only one X chromosome, and it can be transmitted to the carrier mother, who is the carrier, who is having one defected FMR1 gene on one X chromosome because she has another normal X. That is why she is phenotypically normal, and she can have risk of 50% of male children with Fragile X syndrome. Fragile X syndrome is most common inherited cause of mental retardation in male children. That is why we are worried. Whenever a patient come to me with decreased ovarian reserve, I draw the 3 generation pedigree. I ask through the maternal family or her brother having any signs and symptoms of mental retardation, which is very important history in these cases. And so the carrier screening for Fragile X is recommended for women with family history of intellectual disability in male children, 2.5%, and autism due to Fragile X or ovarian insufficiency or failure prior to age of 40 years. So we have to be very cautious in these patients.
Sangeeta,
Ma'am,
please.
here we have a question.
Yes.
Ma'am, we have a question from Dr. Swati. Ma'am, do we have similar mutations in CFTR gene worldwide, or it's different in Indian population?
It is different in Indian population because in worldwide, if I would say, Delta F508 mutation is seen in, I think, 550 to 60% of the cases in Caucasian patients. But in our Indian population, that is not very common mutation. It is seen in 40 to 50, maybe sometimes less. And we have totally different spectrum of mutation. That is why I always advise to cover the full CFTR gene through exome sequencing and not go for the common mutation panel which lab are offering because their common mutation panel that is based on the study of the different European population, not on the Indian population. So we have to cover the CFTR gene, and it is a big gene with 27 exomes. So we have to be very sure that full gene is covered in whatever test you are advising.
Okay,
And
thank you, ma'am. I hope this clears your doubt, ma'am.
and I have a question regarding
Yes,
this DOR.
yes, ma'am.
So I think we do see patients of Turner also, mosaic Turner, especially mosaic Turner is very confusing for fertility point of view because they sometimes they have premature menopause and they come to you, and many of them might have had a child also. We have recently one patient. So mosaic Turners are again very confusing, and these patients, if they come, even preservation is one of the options here. If they are able to come early and they come to you with DOR, and
Yes, ma'am.
similarly FMR gene that way is one area. If see, I practically speaking, DOR and POI are very common. So if you
Yes.
are if the patient opts for donor inside donor egg, then perhaps you may not test it, but it should be tested. I mean, it should be offered to all so that at least in the family they know if any other sibling or any other person is involved, and that can be diagnosed. But if this patient is going for her own eggs, especially in cases of DOR, then I think FMR gene must be done in these patients.
One more point I want to clear, ma'am. If they are even opting for a donor and the history and her clinical profile is suggesting that she might be a carrier of Fragile X premutation, we should advise them testing because this can have repercussion in their later life because Fragile X tremor ataxia syndrome is one condition which is seen in 20% of the patients with Fragile X premutations. So we can definitely make them aware about this problem, and we can counsel them. We can take the precautions related to that. So this is another point. I did not discuss it in detail because that otherwise this requires another lecture. Hello.
Yeah, let's move on. Yeah.
Okay. So now I will be discussing some slides about pre-implantation genetic testing, which is the burning topic nowadays. And any presentation will not be complete without discussing these. So pre-implantation genetic testing, as the name involves pre-implantation, that means before implantation, we do the genetic testing of the embryo samples. So we have different types of pre-implantation genetic testing, that is PGT-A. And this is done for aneuploidies. I will be defining the indications of PGT-A in next slide. And PGT-M is for monogenic disorder. As Jindal ma'am also described, monogenic disorders like cystic fibrosis, thalassemia. We are doing pre-implantation genetic testing very pertinently for every monogenic disorder. We are advising them. And PGT-SR is for structural rearrangements. That means sometimes in RPL patients or in balanced translocation carriers, we have a risk of children with recurrent pregnancy losses or children with malformation. So we advise them PGT-SR. PGT-HL is reserved for HLA typing, human leukocyte antigen, where bone marrow transplantation is required to the sibling. Or maybe sometimes PGT-HLA can be done alone in sporadic cases of malignancies, or in concurrent with PGT-M when previous child is having some condition which is amenable to bone marrow transplantation, and most common one is the thalassemia. PGT exclusion is another category, non-disclosure, that is another category of PGT, where family, one of the partners' family, they have adult onset neurodegenerative disorders, and most common one is the Huntington disease, where partner has not no any symptoms at present because that is the late age onset, and they want their children to be free of this disorder, but they don't want to know their status at present. That is the category reserved for these patients at PGT exclusion or non-disclosure testing. Now, International Society of Reproductive Genetics, they have given in March 2023, they have given some guidelines where we can recommendation where we can do the PGT-A. Advanced maternal age 38 years old and above, 2 or more recurrent miscarriages between 4th and 12th gestational weeks, 3 or more recurrent implantation failures after transfer of cleavage stage embryos or blastocyst with a high morphological score, unexplained severe teratozoospermia with more than 96% of sperm exhibiting abnormal morphology caused by defect in the head, midpiece, and or tail. So these are the specific indications for PGT-A. Now I'll start with a case to decide which PGT for which patients. So one couple came to me, they had previous child with Down syndrome. So now their concern was, what is the recurrence risk? Do we need to go for PGT? So Down syndrome, whenever a patient or couple come to me with a history of Down syndrome in the sibling or in the child, I always ask, take a 3-generation family history. I ask for the picture of the child if they are having, most of the time they are having, because Down syndrome has gestalt feature. I think this can be diagnosed even by common people nowadays. So if the karyotype of the child is this kind, like you can see 321 chromosomes, that is called free trisomy, and which is seen in 96% of the cases, then we can go away with PGT-A if indications are accessible, and NIPT or prenatal diagnosis in next pregnancy. So there is recurrence risk of 1% or plus maternal age. That is the only recurrence risk. But if the child is having this kind of karyotype, as you can see into this karyotype picture, this is a Down syndrome karyotype picture. As you can see, child has got 221 chromosomes. One chromosome is 14, another chromosome 14, but it has got one attachment of 21st chromosome over 14th chromosome. That means technically child has 3 copies of chromosome 21, making himself as Down syndrome. That is called translocation Down syndrome, and most of the time this is transmitted from one of the parent who is the balanced translocation carrier. As you can see in this picture, one of the parent is having one chromosome 21 and another 21 chromosome is attached over the 14th chromosome. So this is balanced translocation because one move to this 14th chromosome. This is the balanced one. That is why during segregation, when gametes were forming, the child got this kind of karyotype from the carrier parent. So in these cases, we have to be very cautious because 2 to 4% cases of Down syndrome can have parents with balanced translocation. And in these cases, we usually advise IVF PGT for structural rearrangements because there is structural rearrangement of the chromosome. We have to look for the embryos. I hope it's clear. And now,
Sangeeta, we go back.
yes, ma'am.
And this child, see, if one of the parent has this kind of chromosome, that
Yes,
means
ma'am.
that this child can have monosomy also, monosomy 21 also.
Monosomy or trisomy, ma'am. While during gamete formation, there can be probability of having monosomy 14, monosomy 21, trisomy 14, or trisomy 21 during
So both
segregation.
possibilities would be there.
Yes, ma'am. Yes, ma'am. All possibilities. But mostly the trisomies, most of the trisomies or monosomies, they are incompatible with life and they can present with recurrent miscarriages. And trisomy 21 is the only trisomy, I think, that is compatible with life.
And see, if if in cases where there is previous baby has Down syndrome
Yes,
and the
ma'am.
parental karyotype is perfectly normal, do we still
Okay.
need to do PGT or prenatal in these patients?
Ma'am, PGT in these cases is as per if indication, another indication is there like advanced
Yeah,
maternal age, where
uh,
there is formation of recurrent aneuploidies. We can advise them in these cases. Otherwise, if free trisomy, we can go away with NIPT also. If ultrasound anti-scan is normal, we can go away with NIPT as well.
and if patient is otherwise going for IVF and wants to be on the safe
Yes,
side,
yes, yes,
yes,
ma'am. That can be offered. There
yeah,
is no harm in offering.
yeah.
So this is another case. This is my favorite case because this couple had previous child with thalassemia major and with compound heterozygous mutation in the beta globin gene, and they were carrier of the thalassemia. Now this couple wanted their another want to have another child free of disease and the bone marrow transplantation for this child also, previous child also. So as we have already discussed, autosomal recessive inheritance of thalassemia, cystic fibrosis, 25% risk of having affected child. So which PGT is applicable in this case? PGT-M and plus PGT-HLA. We did this in our center, I think 2 years back. Now the child is 1 year old and HLA matched to the sibling, and bone marrow transplantation is going to happen in, I think, next
Dr.
2
Sangeeta,
years. Yes, ma'am.
what to do if we get a mosaic pattern on karyotyping when we do amniocentesis and we get mosaic pattern? What to do? Whether to go in for termination or we can continue the
Mosaic for
pregnancy?
which chromosome, ma'am? Hello? Hello? Am I audible?
Yeah, you are
Yes,
audible.
ma'am.
I think ma'am is muted now.
Yeah, I'm
Okay.
second mute. You can answer the question in a generic
Yes, ma'am.
term. Hmm.
So, if suppose we have got the mosaicism for Down syndrome, and now because if all the ultrasound features are normal, there is no structural malformation, no cardiac defect, because mosaic patients usually have milder phenotype as compared to that of full trisomy. So we can counsel the patient. Final call is there because we cannot decide the phenotype at that point in time. After the child is born, we can then comment only on the development of the child. It is very difficult to phenotypically predict.
And also depend on the which chromosome is involved and
Yes,
Thank you.
ma'am. Yes, ma'am.
so
It all depends actually. I'm just taking a common example. So shall I move, ma'am?
yeah, sure. Dr. Serene, if you want to say anything, please go ahead. No. I think you move on. Yeah.
Okay, ma'am. So HPLC cases, I have only only two cases. So first of all, hemoglobin, that is, hemoglobin is made up of alpha and beta globin chains. We know that HbA is composed of two alpha and two beta chains. HbA2 is the another variant which is seen in hemoglobin while doing HPLC. This has got two alpha and two delta chains. HbF is the fetal hemoglobin because that is usually in the fetal period of life. That has got two alpha and two gamma chains. So I got this reference 11 weeks pregnancy, non-consanguineous couple, no family significant family history. So wife was having HbA2 of 5.6 that relates to the thalassemia minor. But overall profile, CBC profile is also suggestive of thalassemia minor status because HbF is also raised, RBC is towards higher side. Hello?
Yeah, carry on.
Okay, okay. And husband was on HPLC. He had CBC was perfectly normal, but on HPLC he was found to have 39.2 retention time 4.2. That means HBD Punjab. Because we usually see these retention peaks, and this HPLC is done to check the HB variants as per their weight and molecular charge. They are eluted on electrophoresis picture. So this was HBD Punjab and wife was thalassemia minor. So most of the time, labs, I don't rely each and every lab. Please don't mind because sometimes labs have different results for HbA2. Some labs they will refer the patient as HBD Iran or something like that. So I usually it is my protocol to confirm the status of the husband and wife by doing beta globin gene sequencing. Maybe if cost is a constraint, at least I will confirm the husband status of HBD Punjab. We confirm the status it was HBD Punjab. And in these cases, usually the clinical consequences are not much, no clinical consequences with thal minor and HBD Punjab. And we don't do the prenatal diagnosis in these cases.
And
Now another,
if both couple are HBD Punjab,
then also no consequences, ma'am.
and I
Because
think
HBB Punjab is the structural variant of HBB gene only, and that usually doesn't cause any consequences because, as you can see, heterozygous husband is also having the normal CBC profile.
And I think this inconsequential genes are there are a lot of such reports. Not only D is common here in our side, but
Yes,
I think
ma'am.
there are lot many other variants are also
Yes,
there.
ma'am. Yes, ma'am. There are so many variants. D Iran, D Punjab, HBE heterozygous, D Lepore. A long lecture is required for that. So this couple, non-consanguineous couple, 14 weeks pregnancy, they were referred to me as for the HPLC report. As we can see, wife was having HbA2 plus E 30%. Husband was having anemia as well as HbA2 plus E 48% and HbAF was 43%. So in wife, it is mostly looking like HB E heterozygous, but we cannot say it with reliability. We have to do the beta globin gene sequencing to find out the proper result. And in husband, he was symptomatic, 7.3. His HB used to remain like this, CBC parameters, microcytic hypertrophic anemia, and A2 plus E, which is slightly higher than the peak of HbE. and HbF was also raised. So we did the beta globin gene sequencing for both of them. Now the wife was detected to have HbE heterozygous status, but husband was found to have HbE as well as Thal minor status. So he was compound heterozygous for both the mutations. So if he would have been HbE heterozygous and wife also HbE heterozygous, we wouldn't have done anything because HbE homozygous doesn't cause any clinical consequences. But in this case, we had to the prenatal diagnosis because Thal minor and HbE, they can have clinical problems later on, moderate anemia, thalassemia intermedia, or thalassemia major phenotype. So if this couple would have come to us in before pregnancy, we would have advised PGT for this case as well. Now I will any doubts till now?
I think somebody asked this question that if she had come before pregnancy, would you go for PGT?
Yes, of course. In these cases, we advise PGT. Shall I move now?
Yes,
So
move on.
my last case is on NIPT. So we had primary patient, 32 years. She was referred because of increased pupil translucency on NT scan that was more than 99 centile. That is more than, I think it was more than 3.5 mm. So what next? Can anybody in the audience, what do you advise in these cases? Or shall I move forward? NIPT, amnio, what do you advise? No. So, first of all, I will discuss the associations with increased NT. They can be chromosomal abnormalities, that can be aneuploidies or microdeletions, duplication syndrome in 5 to 75% of the cases. They can be structural abnormalities that range from 3 and 50%. Most common structural abnormalities, cardiac, followed by pulmonary, GI, GU, and musculoskeletal. Single gene disorders, there can be more than 150 genetic syndromes, and most common one is the Noonan syndrome, skeletal dysplasias. And adverse pregnancy outcomes can also be there, fetal growth restriction. Even if we have done the genetic testing, we have to consult the patient that genetic growth restriction can be there, and we have to be cautious.
Sangeeta, there is one answer to your question, that dual test has to be done first.
Okay, that is okay, no problem. Dual test also showed the increased risk for trisomy 21 now. Okay, so clinician did the NIPT, that was for all chromosomes, and that was low risk. Patient continued with the pregnancy.
So just a minute, Sangeeta, I would like to interrupt.
Yes, ma'am.
You will do dual test or NIPT?
I will not do NIPT, ma'am, because NT more than 99 centile, that warrants something confirmatory like CVS or amniocentesis.
Okay. Dual test, but should be done or?
Yeah, that can be done because we just want to know the PAP-A levels and beta-HCG levels. Dual test is going to be resulting in high risk only because NT is already more than one mom in this case.
So then there is no need for dual test also?
We can skip that, ma'am. If we have decided for amniocentesis or CVS, we can skip that.
Or you can in other words, are you saying that if NT is more than 99th centile, then this patient has to go for amnio only?
Yes, ma'am. Amnio or CVS also.
The other tests do not contribute to decision making.
No, ma'am. Dual test is going. Actually, dual test is derived from the beta HCG, PAP-A, and NT scan report, as you have always seen. So NT is already high, and that is going to be the high risk only.
Okay.
Ma'am, we have another answer to this. Dr. Nidhi is saying the early anomaly scan followed by amniocentesis should be done.
That can be a good choice. Yes. So
Okay.
we have to give the options to the patient that directly for CVS or after level 2, early level 2 scan, because that needs for phenotyping as well. So both the options are okay.
Early normally if we do, so we can find out what are the abnormalities the baby is going to develop. So
Yes.
this will help in
Yes,
sending
yes,
some
that
tests,
can, yes, that can, help
targeted
in
tests.
phenotyping and finding out the, taking out the genes what to be seen. So that is my take on most of the time.
Yeah.
So, clinician did the NIPT for all chromosomes that was low risk. Patient continued the pregnancy, and on level 2 scan, now short long bones, less than percentile. I'm getting some disturbance.
Sir, please mute yourself.
Please mute yourself.
Sir, mute.
Okay, thank you.
So now patient came to me, we did the amniocentesis, and on exome, she was found to have Noonan syndrome. So we have to check the validity of NIPT. Whether it is, most of the commercial labs, they are offering NIPT for all chromosomes, and patient gets reassured that, okay, our risk of having genetic disorders is, totally negligible, and they are so relaxed then level 2 scan comes up with some findings. So NIPT beyond common trisomies, that is has high false positive rate, lower positive predictive value, that can lead to unnecessary invasive procedures. For example, positive predictive value for Turner syndrome that range from 9 to 40% only. And for CNVs, which the lab are usually asking us to do, that is only 14 to 50% depending upon the size of CNV. Only for some cases of 22q microdeletion that can be advised just to stratify the patient whether to do amnio or not. International guidelines, they don't recommend NIT panels to be offered beyond basic common trisomies until further supportive clinical validity and utility. And this is the latest, I think, 2023 article, and 24 also doesn't say anything. Now, adhere to the basic indications of NIPT. NIPT was not made to do check for everything. This is only advisable in advanced maternal age, more than 35 years, intermediate or high risk combined first or second trimester aneuploidy screening results with no structural malformation. Soft markers on ultrasound in isolation, like echogenic cardiac focus, choroid plexus, patelectasis, single umbilical artery. Only one marker, not 2 or 3 markers. In that case, we also again get skeptical. History of prior pregnancy affected by free trisomy 21 NIPT can be done. Advantages for doing only for these indications is that it greatly reduces the number of invasive tests needed, as majority of these women will receive a low risk NIPT results. So what we learned today, I'm on the last slide.
Ma'am, I have a question. Like if the combined testing of a patient aged more than 35 years it's found to be normal, is there still a need to do NIPT, or we can avoid it? And how to counsel that patient in case we avoid it or in case we do it?
So I have first and foremost indication I have written for NIPT is advanced maternal age, because in advanced maternal age we are doing combined first trimester screening. Combined first trimester screening, we have to understand, we have to make patient understand that sensitivity of combined first trimester screening is 90%, even if we have seen everything, because it cannot tell you more than 90%. 10% risk of having trisomy is still left. So if we want to cover, if patient is willing to have that 10% risk also covered, we advise them NIPT. I think NIPT is a good choice for those cases.
Okay, ma'am. Ma'am, here we have a question from Dr. Nidhi. What is free trisomy 21?
Free trisomy, when extra 21st chromosome is lying alongside the 21st chromosome, there is no translocation status of the 21 chromosome with any other chromosome.
Okay, all right, ma'am. Ma'am, Dr. Usha Madan is asking, which is better, dual test or NIPT?
So it depends upon patient to patient, ma'am. I advise, I offer both of them, but mostly in low risk patient, we advise dual test, and we tell the patient that it has got 90% sensitivity. It's patient choice if they really want to go, because American guidelines and many guidelines, they say that NIPT for all. If patient is affording, in Indian scenario, if we have done the combined first trimester screening, that is, I think, mostly enough for all our patients. But if patient is willing for NIPT, we cannot say that it is not a good test for trisomy 21 at least.
Okay, all right, ma'am. Ma'am, Dr. Shivani is asking, is NIPT indicated in every patient with fetal cardiac echogenic foci?
No, not in all cases. We can offer them, but not in every case. Actually, we weigh the taking all genetic history, all 3 generation pedigree, and age of the patient. What are the other parameters which are indicating that we should do NIPT? Then only we advise NIPT. In every case, we advise. Fetal
Ma'am,
echocardiography suffice for these cases.
okay, ma'am. Ma'am, is there any particular number of soft tissue markers? Matlab, we have to advise NIPT more than
If
equal. Or
only one marker is there, we advise NIPT. If 2 or more than 2, it is advisable, depending upon the risk, it is advisable to go for amniocentesis.
okay. Ma'am, another question popping up is from Dr. Swati. What about performing NIPT for all IVF pregnancies?
All
IVF pregnancies.
I don't think there is any indication or any recommendation related to IVF cases. But yes, most of the IVF patients, they are advanced age because they are running from here to there, and they might be having some kind of spermatogenic problems. That they can go for NIPT, but otherwise, it's not. As per my thought, it is not indicated, and no recommendation is also saying that.
Sangeeta,
Okay, all right.
do you think NIPT is taking over in West over dual test
Yes,
and
yes, ma'am. Yes, ma'am. Yes, ma'am. That is taking over. But as per Indian scenario, I think it is not that popular. Definitely,
Ma'am,
if I think about NIPT and first trimester combined screening, NIPT has edge over dual marker or combined screening, that it has got more sensitivity for Down syndrome. 99.6% as compared to the first trimester combined screening, so which has 90%. So we have tell the options to the patient. It is their call what they want next.
okay. Ma'am, what is the role of NIPT in twins? A question by Dr. Usha Madan.
Twins, we can do NIPT.
so there's a
Okay.
separate program for them?
Yes.
They can
Yes.
distinguish between both the fetuses?
Yes. Yes. Usually NIPT can be done for DADC twins.
DADC,
Not
not
for
mono.
monocorion.
Not mono.
No, ma'am.
Ma'am, Dr. Deepa Goyal is asking, what is the role of genetic evaluation in FGR? If yes, in which cases?
FGR, yes, ma'am. In which cases? Early onset FGR. So they require genetic evaluation, ma'am. And when Doppler flows are normal, you are not suspecting any placental insufficiency, then we definitely need to genetically evaluate IUGR cases, because up to 25% of the cases, there can be genetic problem in FGR cases as well, ma'am.
What do you mean by early onset exactly in your terms?
Early onset, maybe at 20 weeks, level 2 scan you have diagnosed.
Okay, so you would recommend an amnio at that level?
Yes, ma'am. Yes, of course, ma'am.
Whenever you are, I think, faced with the decision to whether to continue this pregnancy or to, I mean, if there is a severe IUGR at that stage, so in
Yes, ma'am.
at then genetic evaluation would be the decision making factor.
Ma'am, actually, in FGR cases, it is not straight and simple that we do amnio. Usually, whenever a patient comes to me, I have to take the 3 generation family history, because FGR can be constitutional as well. Because I have to take down the history of the height of the parents, their grandparents, and his sometimes husband or wife, they are having history of IUGR in their prenatal period. So these all account to the management, because only one factor cannot decide whether this is going to be genetic or not. So we have to evaluate the case properly, whether we should go for the testing or not. In most of the cases, I have to go for the genetic testing, because sometimes skeletal dysplasias they also present with early onset FGR. So it is case to case, ma'am. It is not thumb rule for all.
Ma'am, Dr. Ditchens is sharing a case. Wanted to share
बस ठीक है
30.
दरवाजा बंद करना
Dr. Meena, please mute yourself. Ma'am, Dr. Dechen is sharing a case. Wanted to share a 32 years primary NT-NB scan normal. Dual marker was high risk for Downs. NIPT was inconclusive. Sent for
dual
MU
marker
at Jindal
was-
Center.
ये वाला पानी
Ma'am,
और बड़े टब में दे दो
Meena ma'am, please kindly please mute yourself. Yes, ma'am. Thank you. Dual marker was high risk for Downs. NIPT was inconclusive.
Dual
Sent
marker
for
was,
MU.
one second. Dual marker was high risk for Downs.
Right. Yes, ma'am.
May I know the PAP A or beta HCG values, and what was the risk?
Dr. Dechen, can you please help us with this?
Yeah, please unmute yourself and you can communicate.
I think case was 2-3 months back, so I don't actually remember.
Okay, ma'am.
But
Okay.
I had a talk with this NIPT guys, and
Okay.
they were saying it is inconclusive because
For?
they did not say, because of course trisomy 21 is different, and they said they cannot comment on the sex chromosomes. So they told
Okay.
me better go for an amniocentesis. So, and I
Okay.
think I had a talk with Jindal, the genesis there, and she said, okay, send the patient. It came to mosaic positive. And I think
Mosaic
because
for
she was,
which chromosome?
she was Turner mosaic. There was
Okay.
multiple, I think at 3-4 places. I don't even remember. It's just a general statement I was sharing, that we
Yes,
were
ma'am.
under a
Yes, ma'am.
lot of dilemma, because some were saying it's okay, mosaic, she can, you can make the patient understand what all the features and all what can be the repercussion if she continues. But then I kept keeping all the positive, and because she had also 32 years, she had conceived after 4-5 years. When they said,
Yes, ma'am.
they were not acceptable to go on with the pregnancy, and she aborted.
Okay. Okay. So which chromosome, mosaicism for which chromosome was there, ma'am? I need to find out, because counseling for different chromosomes is different, ma'am.
Yeah, I think she was counseled at Jindal only, at your place, your center only.
I
Maybe if you
also
remember,
don't
this
remember.
was
Yeah.
2 months back, I think.
Okay.
This is in May ending somewhere.
Okay, ma'am. So, ma'am, mosaicism, as per in usual cases, mosaicism has phenotype usually milder than the full chromosome anomaly. That I can say, because I don't have any report, so I cannot properly comment which chromosomal mosaicism. But I can only say that spectrum is milder in mosaicism as compared to full karyotype chromosome.
And
Full
Sakita,
trisomy.
how common is it to get an inconclusive report?
Inconclusive report, ma'am, NIPT, because when we are doing it for all chromosomes, that is much more prevalence. But if we are doing only for common trisomies, it is not that common, ma'am. It
And
can be seen in 1 to 2% of the cases.
And
I remember this case.
inadequate fetal fraction is one
Yes,
common.
another problem. Another obese patient, high BMI, there can be problem. We consult the patient
This
priorly.
patient I have seen, Dr. Ditchen had sent here in Jindal Hospital, and this was a inconclusive report on, I think, dual or NIPT, what something. We did amniocentesis, and there was significant amount of mosaicism of chromosome 21.
Well, it depends what
Amount of
percentage
mosaicism,
of
that was
chromosome
29 or
mosaicism.
30% or something.
Yeah.
I'm not exactly remembering, but it was significant amount. a fetal medicine specialist, he advised that this patient should actually not carry the pregnancy forward. So that's why I think termination was advised.
Okay.
I think this genetics is full of surprises and full of controversies, I would say, and especially prenatal and before pregnancy. I mean, it's a really fascinating subject, and it's fast developing, and we need to keep pace with it.
Yeah. Actually, every case is different.
Yeah.
So,
Ma'am,
final.
there's
Hello?
another last question. If there is isolated or multiple soft tissue markers and aneuploidy screen is negative, shall we still opt for NIPT?
I think yes. But NIPT, in fact, I would go for amnio, depending upon the soft markers I am getting. If it is echogenic bowel, then definitely I would advise amnio as compared to NIPT. NIPT will not pick up anything.
Right.
So it depends upon the soft marker, what type of soft marker you are getting, and what is the likelihood of getting trisomy or some another problem with these soft markers. So
Okay.
there is no thumb rule for everything actually.
Yes, ma'am.
So final slide,
Hello.
shall I?
Yeah, sure, carry on.
NIPT can be sometimes inconclusive. We had one patient where
Yes.
dual markers and triple and quadruple, they were both high risk.
Yes, ma'am.
Ultrasound, they were soft markers. NIPT was inconclusive. And then we had to go in for amniocentesis. Luckily, amniocentesis proved to be normal because she was 40 plus with previous bad obstetrical history and conceived after infertility. Now she is almost 28 weeks and pregnancy is going on well with no IUG, no problems.
That's good news, ma'am. Thank you, ma'am. Thank you for sharing. So, final slide, what we learned today, genetic factors in infertility, they require attention because ultimate goal of the fertility treatment is not the conception, but a healthy conception. PGT is the advanced IVF technique, indication and counseling, they vary with the overall genetic profile of the family. Always check the full clinical picture of the couple along with CBC plus HPLC during thalassemia screening. Seek for geneticist help whenever in doubt. NIPT is a still high screening test validated for common chromosomal aneuploidies. Beware of extrapolation of its indications and results. So, our next session is on 5th of September. That is going to be conducted by Dr. Nidhi Sharma. She is our senior IVF specialist. And another event in the corner is the 21st ART update. You all are welcome to our conference, which is happening on 31st of August in Sector 17. So we look forward to see you all in the conference as well as in the fortnightly sessions. Thank you so much.
Thank you very
Thank
much.
you, ma'am.
Any
It was a
last
great
minute
session.
comments or?
I think a
Thank you,
very
Sangeeta ma'am, for
excellent,
such insightful
excellent
session.
session.
Thank you, ma'am.
Very excellent. Learned a lot. Thank you, Sangeeta and Umesh.
Thank you, ma'am. Thank you so much always.
I think we
Thank you,
can.
ma'am. Your talk has truly simplified a complex subject for our practice.
Thank you, Ashima.
Ma'am, with the end of the session, we, the Jindal team, invite you all to join us for 21st ART update, where we'll continue to learn and share the latest updates in the field. We look forward to your presence. Thank you, everyone.